My name is Brian Wood, Medical Director for the Mountain West AETC ECHO. Welcome to this week's session, and I will turn it over to today's speaker.
Great, thank you. I know we've talked about vaccines sort of intermittently when we've talked about cases, and I'm hoping to provide some updates, but still some unanswered questions. So I'd like to get your input about what you're doing as well and what your thoughts are in your clinical practice. So, starting off with a question about zoster vaccination, a 52-year-old woman with well-controlled HIV, a CD4 count that's very good, 600, who's on antiretroviral therapy. She reports that she had a history of shingles 2 years ago. So what do you recommend regarding the zoster vaccine? Again, she's 52 with HIV and has a history of shingles. A, the vaccine is contraindicated given her HIV. The vaccine is not indicated given her history of zoster. Check a VZV titer to confirm the history, and if negative, proceed with vaccination. D, recommend zoster vaccination. E, wait until she's 60. All right, a slight majority voting for going ahead and giving zoster vaccination. A few of you saying that it's not indicated given her HIV or that she's had zoster. A few percent would confirm with a titer, and some would wait till 60. So this is good that we're talking about it since the answers are sort of varied. So this is a slide I think I borrowed from David a long time ago, that we know that zoster is a significant problem and that as people get older, they have a higher risk of developing VZV reactivation, and a third of people in their lifetime will get VZV reactivation. And one of the main problems that we see is post-herpetic neuralgia, which is significant pain that's associated after a VZV reactivation episode. So this is the original zoster vaccine, the live zoster vaccine known as Zostavax study that led to its FDA approval, which was a large randomized controlled trial that really showed that it was pretty effective in reducing not only incident herpes zoster, but also post-herpetic neuralgia. So 50% or greater reduction in incident herpes zoster cases, as well as a 2/3 reduction in post-herpetic neuralgia. One of the things about this vaccine, as we know, is that it's a live vaccine. And it has been an issue in terms of our patient population in HIV because we don't have really good data. There was one abstract, but that was never published about its safety, although we don't know a whole lot about efficacy in patients with HIV. And the recommendations by the ACIP have not changed, though, and it's just a blank, as we all know, not recommending vaccination but not contraindicating for patients with CD4 counts greater than 200. So the official guidelines that came out were that it's for age greater than 60 or 60 and over, but it excludes patients with contraindications to live vaccine, including HIV. But you can give it to people regardless of their history of whether they've had zoster. And it included patients who have diabetes and heart disease and other chronic medical conditions, again, not immunocompromising conditions. It's a single dose vaccine. The FDA approval for the vaccine is 50 and over, so as many of you have realized in practice that patients come in their 50s and want the Zostavax, but even though it's FDA approved, the ACIP guidance is for 60 and over, so payers may not pay for it if you're under 60, and that is variable. There was a re-review of the literature by CDC and the immunization committee, the advisory committee on immunization practices, to re-review that 50 to 59 age group. And basically what they did was affirm their recommendation that it should be for 60 and over, even though the FDA approval for Zostavax is for 50 and over. And the concern was that people would have waning protection over time, and during their highest risk of VZV reactivation, which is really in the 70s and 80s, that they may not, in their 70s and 80s, they may not have enough protection to prevent VZV reactivation. So, in terms of the answers here, really based on guidelines, the recommendation would be 60 and over if she didn't have HIV. Because she has HIV, we don't really know. the primary care guidelines that came out in CID a few years ago, clinical infectious diseases a few years ago, by Judy Aberg and Joel Gallant, actually said to give Zoster vaccine, the live Zoster vaccine, for patients 50 and over. We actually have no data guiding that recommendation. And again, like I mentioned, there's a blank box on what to do. But fortunately, we have a new vaccine. There's a new recombinant Zoster vaccine that was just approved. It's not yet available. It should be available this first quarter of 2018. So I wanted to spend a little bit of time talking about the data that went behind the approval and what that means for our patient population. So these are slides courtesy of David, who always has beautiful illustrative slides. So varicella zoster virus is there, and then the Zostavax is a live attenuated vaccine. It's actually the same strain of virus that's used for the varicella vaccine, which is, there are good data for in HIV-infected children that's extrapolated to adults. So we know that with children with a CD4% greater than 15, that it is safe to use. And what the difference between the varicella vaccine and the Zostavax is that it is, even though it's the same strain of virus, which is the OCA strain of the virus, it's 14 times more potent. And so there is a concern that maybe there would be more issues with it being a live vaccine. The new vaccine, the new recombinant vaccine, which was previously called HZSU, is now being called RZV. So when the new immunization schedule comes out, there will be the new nomenclature for it will be recombinant zoster vaccine, and the VZV vaccine, Zostavax, will be referred to as a live zoster vaccine. So it's a subunit vaccine. So what that means is it takes one aspect of the virus and uses it to create the vaccine and uses an adjuvant system. The glycoprotein E that is used in the vaccine is important in the natural immune response to zoster. It's an important factor in viral replication and also cell-to-cell spread of infection. So this is an excellent target for this vaccine. And the adjuvant basically stimulates a greater immune response. When we're using a not live vaccine, what we want is a booster for the immunologic effect to get a sustained and potent immunologic response. So the RZV vaccine, which is called Shingrix, the initial study that came out in 2015 called the Zoe 50 study looked at prevention of first episode of zoster in immunocompetent individuals. It was a very large multinational, I think 18 countries, an N of over 15,000 individuals split into placebo and vaccine group. It excluded those, however, with a prior history of zoster or who are immunosuppressed. So we're looking really at first episode prevention. And it excluded those previously vaccinated against varicella or zoster vaccine. And so here are the data. This is a slide from David that looked at efficacy, again, the primary endpoint being prevention of first episode of zoster. So 97% reduction in cases. So there were about a little over 200 patients, I think 211 patients in the placebo group that had an incident case of zoster versus 6 in the vaccine group. So pretty effective vaccine. And what also was remarkable is that, so these were all patients greater than 50, but they looked at them by age 50s, 60s, and 70s, and they found that the efficacy was similar. And why they did this is because when they went back and looked at the data from the Zostavax and efficacy, I mentioned a 51% efficacy in reduction of incident zoster. When you looked at it based on age, patients in their 50s had a much greater vaccine efficacy than patients in their 70s and 80s. So when they were in their 70s and 80s, efficacy dropped to about mid-30s compared to 60s in the younger group. So the difference with this recombinant vaccine is that we have preserved efficacy regardless of advanced age. The issue with the vaccine that I wanted to bring up is that there are some differences in safety. So 84% of patients given the vaccine did experience some side effects versus placebo, which was 37%. Majority of patients had local site pain. Not an insignificant number had redness, swelling, myalgias, fatigue, fever even. And 17% of patients had symptoms that prevented actual normal everyday activities, meaning a grade 3 or higher. So that's not an insignificant percent. These are definitely higher than in what we saw in terms of adverse effects in the live vaccine that was available, that randomized control trial with the live vaccine. This study, which is the ZOE 70 study that came out a year later, really looking at patients older than 70. So these patients were in their 70s and 80s, and what they wanted to do was really demonstrate that it could be as potent in these older individuals as in the younger individuals, and really greater than 90% efficacy again in the older individuals. So this led to some preliminary, so the Advisory Committee on Immunization Practices has a group that was looking at RZV and came out with some preliminary recommendations that should be incorporated in the 2018 vaccine schedule that comes out every year in February. So in a few weeks, we should have formal guidance from CDC regarding the use of this vaccine. But when they voted on the vaccine a month or so ago, these were the recommendations. All immunocompetent persons aged 50 and greater, regardless of history of shingles, should get RZV. All immunocompetent persons greater than 50, regardless of prior LZV vaccination. So I'll mention that that original study, ZOE 50, excluded these patients, but and then there was a split vote, 8-7, in favor of preferring RZV over LZV. So really not a huge majority there. It was just one person greater that was preferring RZV. And there was a much debate about whether they should prefer RZV. So the pros of RZV are that it's not live. So for our patient population, really definitely a plus. We know from data with HPV vaccination that it's really safe with these subunit vaccines. These are not, that's also not a live vaccine, it's a recombinant vaccine, and so we shouldn't really see any differences in terms of safety. And it's better efficacy in older individuals, suggesting that it is more immunogenic, which would be also preferential in our patient population. The cons are that it's 2 doses, and there are potentially more local site reactions and side effects with the RZV. So I'm not sure in what's going to be in the official guidance in a few weeks whether there's going to be a preference. I have a feeling that they're going to include both vaccines in the vaccine schedule and let market forces decide what happens with the LZV over time, as more people are probably going to adopt to the RZV. All right, I also wanted to talk about meningococcal vaccine because I know that there are some non-believers in the audience about vaccination with meningococcal vaccine for HIV-infected individuals. So 32-year-old man with HIV, also well-controlled HIV with CD4 count 375, presents for a routine visit. He inquires about vaccination. So which one of the following is most accurate regarding meningococcal vaccination? It's not needed unless he's traveling to endemic areas. Give the conjugate meningococcal vaccine, or give the polysaccharide meningococcal vaccine, give meninge-B vaccine only, or give both the conjugate and meninge-B vaccines. So not an overwhelming majority for any particular answer. So about a quarter of you saying no, almost half saying yes, give the conjugate, some for polysaccharide, some for meninge-B only, and then some for both. All right, so this is a slide from David also, just showing what's in the quadrivalent vaccines. There's 2 types of quadrivalent vaccines, the conjugate and the polysaccharide, that include ACY W135, but don't include B. But B is an important one in terms of outbreaks. And those of you in Oregon probably know that more so than any of us right now, since there has been an outbreak at OSU. So here are the 3 currently available, or actually I shouldn't say available, FDA-approved quadrivalent vaccines. Menactra and Menveo are both conjugate vaccines. And MedImmune is a polysaccharide vaccine. For those of you who've tried to order MedImmune, you'll know that it is actually not at all available. It is the only one that's actually approved for age 55 and over. However, as you can see, because the Menactra and Menveo stop at age 55, but it's actually the only one where we don't have data in HIV-infected individuals. So even though it's the one approved for 55 and over, 1, it's not available, and 2, it's not. There are no data in HIV-infected individuals, so you can pretty much rule that one out. So we're really talking, when we're talking about vaccines, quadrivalent vaccines, we're really talking about conjugate vaccines for meningococcal prevention. So the recommendations that came out not that long ago are that for all HIV-infected persons age 2 and older, that they should be getting vaccinated with either of the conjugate vaccines, Menactra or Menveo. The vaccine should be given, if they've never received vaccination before, they should receive 2 doses 8 to 12 weeks apart. If they've been previously vaccinated and are greater than 7 years of age, they should receive repeat vaccination every 5 years throughout life. Just a show of hands, how many of you are doing this recommendation? So 2, oh no, maybe 3. Some people are, sometimes maybe. All right. So why did they issue this recommendation? So we know that Neisseria meningitidis, which causes meningococcal meningitis, is the most common cause of bacterial meningitis in children and young adults in the U.S. We know that based on surveillance data in the U.S. and a sampling of 13 states and looking at epidemiologic survey data and diagnosis codes, that there is an increased risk of meningococcal disease in HIV-infected versus uninfected persons, anywhere from a 5 to 24-fold increased risk, and particularly for those with low CD4 counts and high viral loads. The surveillance data from 2000 to 2008, again in a sampling of states, identified 32 cases of meningococcal disease in HIV-infected individuals, which was an overrepresentation of in terms of percentage who were HIV infected in the cohort and the percentage who had disease. So 2% of all meningococcal disease cases were in HIV infected individuals. So some of you may say, okay, that's 32 cases. That's not that many. I live in a pretty small community. We don't see any meninge. Why should I worry about it? We have seen outbreaks of meningococcal disease in MSM, not just HIV-infected MSM, but in MSM in large urban settings who have been particularly in bathhouses. And there have been outbreaks reported in New York, Chicago, and in Los Angeles that have led some of those public health jurisdictions to actually push meningococcal vaccination, not only in HIV-infected individuals, but also HIV-uninfected MSM. That is not an ACIP recommendation or CDC recommendation currently to give it to high-risk MSM, just to HIV-infected individuals, all individuals, and not just HIV-infected MSM. So what about the meninge-B vaccines? There are 2 currently available, Vexero and Trumemba, that were FDA approved just in the last few years. And this is something that is not a routine recommendation to give meninge-B vaccination. So when you look at the 2017 vaccine schedule, it is to be considered for certain groups of individuals. So who are those certain groups of individuals? So it's recommended currently for individuals who are in a meningococcal outbreak setting. So I brought up the OSU student. I think there have been 7 documented cases of meningococcal meningitis from that outbreak. Asplenia, complement deficiency, and I'm sure all of your patients on this monoclonal antibody that I can't pronounce, and then any microbiologist with potential exposure to Neisseria. So it's a pretty small group of individuals generally you're going to be considering doing meningococcal B vaccination. I think we're going to revisit this as we see potential outbreaks in the college setting, because actually OSU has mandated meningococcal B vaccination prior to returning to school. So over the Christmas holiday, you had to be vaccinated and show documentation of vaccination to come back to class, actually. So we may see some liberalization of meninge B in that sort of crowded setting, like dormitories. The ACIP guidelines would recommend meningococcal conjugate vaccination. But I think you all that are not doing it routinely do bring up a good point that incidence is really low. I think the concern is really that it's a serious infection, and if there is concern for increased risk in HIV, that we should be protecting our patients. I don't know about this repeat every 5 years, which is similar to the asplenic guidelines. There's not really probably a lot of data to support that vaccination, to support that recommendation. It's probably extrapolated from these other immunocompromised groups. So I don't know if there's going to be a lot of uptake or even remembering to do that with all of our other healthcare maintenance that we have to remember to do in 5 years, that issue. So lastly, I just want to bring up that there was a new Hep B vaccine approved in November called Heplisav.
But most conveniently, hepatitis live save. That's what it's supposed to be.
Oh, yeah, really? Okay. It was FDA approved for all adults age 18 and over, and really it's in a push to try to get more people vaccinated at risk. And so this is still, even though it's a universal vaccination for kids, there's still, in terms of certain groups that we target Hep B vaccination for, obviously all of our HIV-infected patients should be getting Hep B vaccination. It's a recombinant vaccination. It's a 2-dose schedule compared to the 3 doses of the currently available hepatitis B vaccination. So that is a benefit. And also it can complete it in 1 month. So how many of you have patients that get a dose and then forget to come back, or you forget to give it at the subsequent dose because you're thinking about other things? So this is a more rapid vaccination schedule. It's probably going to be included again in the 2018 immunization guidance for vaccination. So you'll probably see more people using this to try to get their patients vaccinated.